up next, I have a privilege in introducing Dr. Brooke Cherven, an assistant professor in the Department of Pediatrics at Emory University School of Medicine and a nurse scientist at the Aflac Cancer and Blood Disorders Center at Children's Healthcare of Atlanta. Her research focuses on reproductive health among adolescents and young adult cancer survivors, as is informed by her clinical experience as a pediatric oncology nurse within the Aflac Cancer Survivor and Fertility Preservation Programs. With support from the NIH, NINR K23 Career Development Award, she is identifying decisional and contextual factors that influence pursuit of fertility status among young adult female cancer survivors. This work will inform the development of future psychoeducational and decisional support interventions for survivors who are interested in fertility assessment. In her role as a nurse scientist, she provides research mentorship to nurses and advanced practice providers in the Aflac Cancer and Blood Disorders Center. She also serves as the vice chair for the Children's Oncology Group Adolescent and Young Adult Sexual Health Task Force. Let's all welcome Brooke.
Thank you. Thank you so much. It's such a pleasure to be here with all of you, to see many of you in person again, and to talk about our research that's grounded in the Survivorship clinic, where we have focused on fertility status assessment among our young adult cancer survivors. So today I want to start with a little bit of an overview from a clinical perspective of our care for pediatric cancer survivors, highlight our findings related to interest in a fertility status assessment and worry about infertility among our young survivors, and then discuss some of our active and future directions for research. So to set the stage, I want to give an overview of our pediatric cancer survivorship care. And some of this was highlighted earlier today by Dr. Kim. We have seen huge and dramatic improvements in survival rates for pediatric and adolescent cancer over the last few decades. Much of this is due to the incredible collaboration through cooperative groups and consortia like the Children's Oncology Group. This has led to survival rates that are over 80% generally for childhood and adolescent cancers and approaching 95% for some diagnoses. And it's resulted in a growing group of young adults who are survivors of pediatric cancer. There's an estimated 400,000 survivors of pediatric cancer who are now in their young adult years, which are also their reproductive years. These cancer survivors are at risk for a variety of different late effects depending on the types of treatment that they received. This can include cardiovascular, pulmonary problems, subsequent malignancies, and of course, infertility. When we provide care to pediatric cancer survivors, we begin seeing them generally around 2 years after they've completed their cancer treatment, and we see them annually in a pediatric cancer survivor clinic. This is really the purpose of our care, is focused on the screening and early detection of those late effects. So if they're at risk for cardiac problems, doing echocardiograms, pulmonary function tests, and other screening tests to help early identification and intervene when possible. We'd spend a lot of time doing patient and family education and teaching self-advocacy skills, particularly to survivors as they're aging from adolescent into young adulthood. And we use the Children's Oncology Group long-term follow-up guidelines, which are an extensive set of guidelines. If you're not familiar, they're like 225 pages long. And they delineate, based on therapeutic exposures, what types of risks, what type of health problems survivors can develop, and recommended screening, the types of screening, and the intervals for screening. And this really serves as a framework that we use to develop an individualized survivorship healthcare plan for each one of our patients. This survivor plan delineates the types of screening that they should receive, and this screening is really recommended to be annual and lifelong. Infertility after pediatric and adolescent cancer therapy is is always, of course, a distressful and a clinically significant problem. About 50% of males and 20% of females will experience infertility, but of course it's related directly to the types of gonatotoxic exposures they received, including alkylating agents, radiation, surgery. And we know that in their adolescent and young adulthood years, survivors report that infertility is one of their top concerns, that they can experience fertility-related distress, and that this distress can be related to overall poor quality of life or poor mental health outcomes. So in the survivorship clinic, our goals include discussing with patients after treatment what their risk for infertility is based on the therapeutic exposure. So that's kind of incorporated into their survivorship healthcare plan. Reviewing with them if they did participate in fertility preservation at the time of diagnosis, if they have cryopreserved specimens or samples like sperm or eggs or tissue, making sure that they know that they have those samples, they know where they are, how to locate them, how to use them in the future if they're interested. And then as part of further discussion, we talked to them about fertility status assessment. And we consider fertility status assessment for males to be a semen analysis, which generally can be offered as early as 2 years after the completion of therapy, depending on the age of the patient. And for females, a formal consultation with a reproductive specialist, which can include hormonal evaluation and an antral follicle count. We also sometimes will discuss other family building options, including the use of donor eggs or embryos, surrogacy, or adoption. In terms of prior research that we've done in our clinic, we know that survivors often have discordant perceptions of their risk for infertility, meaning that some survivors who received gonatotoxic treatment are unaware that they're at risk for infertility, and others who did not receive any gonatotoxic therapies are unnecessarily worried that they're infertile. So we've done some research to improve knowledge among our patient population through the Infertility Knowledge Study. This was an educational intervention that was led by Dr. Meacham in our clinic, and we focused on survivors around at the age of 18 to align kind of with the time when we can encourage parents to leave the room, when they're kind of transitioning to having a little bit more management of their own health care, to really have this individualized, tailored fertility-focused discussion that was delivered by one of our endocrinology providers in our survivorship clinic. Patients received their kind of tailored risk for infertility. These discussions were guided by sexual health communication theory. They received a personalized handout, and then we also implemented teach back, meaning the providers asked patients, now tell me what you know, are you at risk for infertility, what level? And we saw that this intervention improved overall knowledge in our patients. So we've made some improvements there in terms of knowledge, but there's still gaps that remain in terms of what patients know or understand about their actual fertility status. Now they know whether or not they're at risk, moving to the next step in terms of their actual fertility status. So that's the focus of our current research in our survivor clinic. And this next set of data that I'm going to present was funded through a Children's Oncology Group nursing research discipline grant. So we focus on the population of emerging adult cancer survivors, and I've actually heard several people throughout the last 2 days mention this, and I don't know if everyone is, some of you may be very much experts in this area, but if not everyone may have heard this term before. When we talk about adolescents and young adults in the cancer community, it's a huge age range, 15 to 39, which is incredibly varied in terms of developmental status, lifestyle, milestone attainment. So when we use a developmental lens, emerging adulthood is a time of transition between adolescence and adulthood when these young people are gaining more independence, further developing their identity. They're attaining educational milestones, entering the workforce, maybe developing more serious romantic relationships. And it's really a time of exploration, feeling a little in between, and it's a time that can be right for family planning and reproductive health needs. And this generally aligns with the ages of 18 to 25. So that was kind of our focus in terms of our population. The concepts of interest, I mentioned earlier that we've defined fertility status assessment as a semen analysis for males and a formal consultation with a reproductive specialist for females. We are, as I'm sure many of us are aware, we're very have a little bit of a sense of urgency for females because they may have a window, a reproductive window that's shortened compared to their peers. And so after treatment, getting them connected and having a fertility status assessment may help kind of elucidate options for biological parenthood, or if they choose to take part in fertility preservation after treatment. And Dr. Sue, last week, I think during the webinar, she did a really nice job of kind of presenting the AMH trajectory data, and in terms of kind of what those different reproductive windows can look like depending on treatment exposures. So the infertility knowledge study, those fertility-focused discussions have now become part of our standard of care in our survivorship program. And again, we're focused on patients at age 18. Our providers often will have a second conversation with them when they're about to transition out of our clinic around the age of 21. And sometimes they may have even more than 2 discussions, depending on the patient's preference. These discussions begin with obtaining permission and kind of letting the young adult guide us in terms of whether they're okay with having these discussions, assessment of worry, if the patient's worried or concerned about infertility. They receive their tailored education about their risk for infertility, and then there's a discussion of further assessment, including referrals for fertility status assessment if patients are interested. And all of these data are documented in a standard note in our electronic medical records. So we felt like this was kind of a nice opportunity to look at some of these outcomes in the context of clinical encounters. So the aims of our studies were to describe the proportion of survivors who were interested in a fertility status assessment, identify factors that were related to interest, and then describe the proportion who had received a fertility assessment. We focused on survivors who were 18 to 25 years of age to align with that developmental period of emerging adulthood, and who had completed a visit in our cancer survivor program between 2017 and 2019. We excluded patients who were not at risk for infertility, so they didn't receive any gonatotoxic exposures. They don't generally receive this same fertility-focused discussion, and those who were less than a year from treatment completion. Of the 308 patients that we identified in our records, we excluded 49 because they did not either did not have a fertility-focused discussion for a variety of reasons, including cognitive delay or scheduling issues, or for those who had initiated that fertility discussion or perhaps pursued a fertility status assessment younger than 18 years of age. We felt like the decisional factors that decisional process that they went through during adolescence is different than what happens in emerging adulthood. So we ended up with 259 survivors in our analysis, and this it's important to note that this does not represent brain tumor survivors. Our brain tumor survivors are followed in a separate multidisciplinary clinic, and their fertility-focused discussions are a little bit different. So we abstracted this data from the medical records. We decided to analyze males and females separately because the process and kind of the outcome for fertility assessment is different for males and females getting a semen analysis and kind of having more definitive results versus establishing care and doing an initial consultation with a reproductive specialist. So we wanted to see those, how we thought the factors might differ for males and females. And then we developed multivariable logistic regression models to identify factors that were associated with interest in fertility assessment. So in our sample, we had 115 females and 144 males. The average age at their first fertility discussion was 19. And while we looked at 18 to 25-year-olds, most of these patients were between 18 and 21. They were about 8 years from the completion of their cancer treatment. Just over half were non-Hispanic white. We saw a similar variety in cancer diagnoses as we normally see in our Survivor clinic. We categorized participants as low, moderate, or high in fertility risk, and this was using the clinical consensus that was used when patients received counseling in 2017 through 2019, so it aligned with what they had heard from their provider. And we did see that there was a larger proportion of males who had either received a fertility preservation consult or had sperm banked at the time of diagnosis. Almost all of these patients were diagnosed before we had established our fertility preservation program, which is why these numbers are so low. They would be much higher today. But on average, they were about 8 years from the completion of their cancer treatment, which means they were probably 9 or 10 years from diagnosis. And then also, about half of them were prepubertal, so there were very limited options for fertility preservation when this population of patients were diagnosed. And then, like I said, we aim for one discussion at 18, another one at 21, sometimes more in between. So about 2/3 of the sample had one discussion, and another third had 2 or more. So we looked at whether patients had reported worry, interest in a fertility status assessment, and if they'd completed an assessment. For females, we saw about 72%, and males 57% reported that they were worried about infertility. About half reported that they were interested in a fertility status assessment, and 9% of females and 3% of males had gone on to complete a fertility assessment. These numbers for the completion of a fertility assessment may definitely be an underreport. Patients may have completed a fertility assessment and not reported back to us. We follow up with them during subsequent clinic visits, sometimes through follow-up phone calls. Our partner reproductive clinics will often send us records, but it's certainly possible that they had gone on to have an assessment and it wasn't reported back to us. But this is somewhat consistent with what we've seen in the literature, where even with some survivors that are a little bit older than this, most of them say they're interested in an assessment, but only about 10% or maybe 20% have actually pursued an assessment. So in terms of factors that were associated with interest, for females, we saw that 2 or more fertility-focused discussions during their survivorship clinic visits and worry about infertility were associated with interest. Insurance type met inclusion criteria for the parsimonious model, but did not meet statistical significance. And for males, we also saw more than one fertility discussion and worry were associated with interest, but they also, for males, fertility preservation consult or sperm banking at diagnosis and being at high risk for infertility were associated with interest. So kind of the summary of these findings, a large proportion of our patients are interested in a fertility status assessment, and worry and more discussions about fertility are associated with interest. Among males, additionally, being at high risk for infertility or having interacted with the fertility program at diagnosis through sperm banking or a consult are associated with interest. And despite this interest, few survivors have completed a fertility assessment, particularly during these kind of early emerging adulthood years. So as we were thinking about these findings, we were pretty interested in, struck that worry was associated with interest amongst both males and females, and that it was, for females, was almost 4.5 times more likely to be interested if they had reported worry. And again, this is a pretty young population, so these are people who are really just entering into that emerging adulthood, just entering out of adolescence. So we wanted to look at factors that were associated with worry. So just as a kind of refresher, 2/3 of the sample reported worry about infertility. And we used a similar approach developing logistical regression models. We found that compared to males, females were almost 3 times more likely to report worry. Solid tumor diagnosis, those who were at moderate and high infertility risk level, and those who had more than 2 discussions were also associated with worry. And when we look at these factors individually, you'll see that females, 3/4 reported worry compared to just over half of males. For solid tumor survivors, about 80% compared to 54% of leukemia survivors. Those who were at moderate and high risk, almost 80% reported worry. And similarly, those who had more than 2 discussions. Again, for the discussions, it's a little tricky. We can't discern the temporal relationship, so people who were worried may be more likely to have more discussions, or people who had more discussions may have like kind of peaked their worry. It's really not possible to discern that from this data. But when we think about these findings in context of survivorship, particularly pediatric cancer survivor clinics where we're still caring for these patients in their late adolescence and their emerging adulthood years, we see that survivors are worried about future infertility, many of them years probably from when they are planning to start their family, or when they're getting close to trying to conceive, that they're still having these kind of concerns. And there's a large proportion that are interested in a fertility status assessment, but it's difficult to discern when survivors want to pursue a fertility assessment. And for females, again, there's this sense of urgency to optimize biological options for parenthood within their reproductive window. And that worry for infertility might be mitigated by connecting with reproductive health services and completing a fertility status assessment. It may also cause further distress for some survivors, and so making sure that we have kind of psychological follow-up for these patients is important. So I just want to finish by highlighting our current research, which is the Survivor Fertility Assessment Study. So these preliminary data kind of served as the basis for this current study, where the purpose is to explore the perceived reproductive health needs of emerging adult female cancer survivors, so we're just focusing on females, and identify the decisional and contextual factors that influence pursuit of a fertility status assessment with a focus on this developmental period. So we're using a sequential mixed methods design and recruiting female cancer survivors 18 up through 29 years of age who've received prior gonatotoxic treatment. And the goal is that these findings can certainly contribute to our shared decision-making conversations with patients, can inform the development of decisional support interventions, and potentially other reproductive health-focused interventions as well. So I wanted to just highlight our study conceptual model so you can see some of the variables and the concepts that we're studying. This is informed by the Ottawa decision model, where high decisional needs can influence decisional conflict and influence the emotion that's associated with decisions and behavior. So we are interested in looking at sociodemographic and clinical characteristics, but particularly those developmental factors associated with emerging adulthood, and that those factors may influence reproductive knowledge, reproductive values and behaviors, and that these together may contribute or be related to decisional conflict. And our outcome of interest is whether or not is fertility status, the receipt of a fertility status assessment, but really understanding how these factors contribute or influence or related to the receipt of a fertility assessment. And then we're looking at decisional satisfaction as a potential outcome for a future interventional study. We are conducting, as I mentioned, a mixed method study. So the first strand is a quantitative strand. We're recruiting 325 female cancer survivors from 4 pediatric cancer centers across the country. So the Aflac Cancer Center will be the coordinating center. We're working with Karen Burns and her team at Cincinnati Children's, Jenna Soapfeet and her team at Children's Hospital Colorado, and Holly Hofkin and her team at Children's Hospital St. Louis. And we'll use the findings from this quantitative survey to identify the sample for the subsequent strand, which is qualitative interviews. And so we'll be able to explore some of the findings from the survey in these interviews, and we'll use maximum variation sampling so that we have representation of survivors from who both have and have not received a fertility assessment, and representation across sites. And we'll be exploring other reproductive health outcomes of interest as well. So in conclusion, I think these findings demonstrate that emerging adult survivors are worried about infertility and they're interested in fertility status assessment, and that decisional support interventions are needed and that they need to be really developmentally informed. And I want to thank my incredible research team, Dr. James Klosky, Dr. Mertens, Rebecca, and Ebony as part of my team, and Aaron Van Cedars, and then of course our fertility clinical team, who are excellent partners, Dr. Meacham, Megan Pruitt, James Ludeman, and Sonia Hoy, who are all here. And then of course I acknowledge my funding from Children's Oncology Group and National Institute of Nursing Research.
Thank you so much, Brooke. We are so excited to take some questions for anybody.
Brooke, thank you so much. I don't have a question. I just want to make a comment and thank you for your work. There's so many, the data shows that a lot of patients don't come back and use their gametes, and so we're doing all this work and they're not coming back. So really understanding why that is super important. You are a lioness.
Oh, thank you, Leslie.
Hi, I just had a question, even just a ballpark, and I know this is gonna vary by region, but what is the cost associated with a fertility assessment at an REI clinic? I noticed there was one slide that talked about Medicaid or what the insurance carriers are for a lot of these young adults. So yeah, just out-of-pocket costs, and are you finding that insurance is covering these fertility assessments in any capacity?
It can definitely vary, but in general, the insurance will often cover the first assessment, but there's often perceptions by survivors that it's not going to be covered or it's going to be more expensive than it is. And there's research too that even oncology providers overestimate how much fertility preservation costs. And so I think there's an actual cost barrier, absolutely, and there's a perceived cost barrier as well.
Thank you so much, Brooke. And I think too, everything you stated also makes me flash access, for these patients. I think we're just gonna learn so much from you so that we learn, what are things we can do better now to prepare for the future. So thank you so much, I appreciate it.